Welcome to part 3 of my presentation, An Introduction to PharmaCare, Drug Prescribing, and Working with Pharmacists in BC. In this video, we're going to take a look at BC PharmaCare. Let's begin by reviewing the various BC PharmaCare plans. The first plan is Fair PharmaCare. This plan is also called Plan I, and most BC residents fall under Fair PharmaCare. Fair PharmaCare is income-based, and we'll be talking about Fair PharmaCare later on. Plan B are for permanent residents of licensed residential care facilities. Plan C is for patients who are receiving income assistance. Plan D are for patients who are registered with a provincial cystic fibrosis clinic. Plan F is for children who are receiving assistance through the at-home program. Plan G is for mental health clients for whom medication costs are a barrier to treatment. Plan P are for palliative patients who are receiving care at home. Plan W are for patients who are receiving First Nations health benefits. And Plan Z, which is also called Assurance, is a newer plan. Any medication that's listed in the Plan Z formulary is provided free of charge. Individuals must be residents of British Columbia and have active coverage through MSP, or the Medical Services Plan. At the moment, there's only one drug in the Plan Z formulary, and that's mivigamiso, a combination product of mifepristone and misoprostol. This is the website for Fair PharmaCare registration. I usually suggest to all my pharmacy students to register for Fair PharmaCare so that they can explain the process to their patients. One thing to note is that in addition to providing your usual personal information, you'll also need to provide your income from your last tax return. Also, an important part of the registration process is to provide authorization for the BC government to access your federal tax return every year to monitor your income in order to adjust your Fair PharmaCare deductible and maximum. Patients who refuse to provide this authorization will not be able to register. So what is so fair about Fair PharmaCare? This table shows the Fair PharmaCare assistance levels, and you can see that a person's deductible and maximum is based on their income. So for example, if a person's net income is $40,000, then PharmaCare sets their deductible at $1,100 and their maximum at $1,500. A deductible is the amount that a person must pay before PharmaCare will start to pay anything. A maximum is the amount that a person must pay before PharmaCare will pay all of their eligible prescription costs. This table shows the enhanced Fair PharmaCare assistance levels. Again, you can see that a person's deductible and maximum is based on their income. In order to be eligible for enhanced Fair PharmaCare, you need to be born before 1940. Compared to the regular Fair PharmaCare assistance levels, recipients of Enhanced Fair PharmaCare have a lower deductible and maximum. So for example, if a person who is born before 1940 has a net income of $40,000, then PharmaCare sets their deductible at $400 and their maximum at $800. This figure is something that my pharmacy students like to call Tony's PharmaCare chart, and it's a good visual aid if you've never dealt with PharmaCare or insurance plans before. It begins with two horizontal lines. The bottom horizontal line is a patient's deductible, and the top horizontal line is a patient's maximum. Again, a deductible is the amount that a person must pay before PharmaCare will start to pay anything. A maximum is the amount that a person pays before PharmaCare will pay all of their eligible prescription costs. I then add some vertical lines. On the left is a line that starts with January at the bottom and December at the top. This represents the fact that a person's PharmaCare deductible and maximum is annual. On January 1st of every year, a person's PharmaCare deductible and maximum rolls back to zero, and they have to start paying again. The middle vertical line shows the amount of money the patient has spent. At the beginning of the year, they spent a little bit, and as the year progresses, the patient has paid more. The vertical line on the right shows that a person must first reach their PharmaCare deductible before proceeding to their maximum. Finally, I define three zones. Starting from the bottom, I call these zones X, Y, and Z. And this is what happens when a person is in each of these three zones. In zone X, a patient has not yet reached their PharmaCare deductible. When a patient is in zone X, the patient pays 100% and PharmaCare pays 0. At the other end of the spectrum, we have zone Z. This is when a patient has reached their PharmaCare maximum. When a patient is in zone Z, the patient pays 0 and PharmaCare pays 100% of eligible prescription costs. In between zone X and Z, we have zone Y, and this is when a patient is between their deductible and maximum. When a patient is in zone Y, they pay 30% and PharmaCare pays 70%. However, if the patient was born before 1940 and is receiving enhanced PharmaCare coverage, instead of a 30-70 split, there's a 25-75 split. The patient pays 25% and PharmaCare pays 75%. Every year my pharmacy students ask me, is 1940 a fixed year or does it change from year to year? 1940 is a fixed year, and the reason for this is because PharmaCare is gradually reducing the number of patients who are eligible for enhanced PharmaCare coverage. Eventually, everyone who is between their PharmaCare deductible and maximum is going to be receiving the 30-70 split. This is a very common question that we get asked in the pharmacy. Why am I paying when my drug is supposed to be fully covered? Well, actual reimbursement actually depends on a couple things. It depends on the patient's PharmaCare plan, and also it depends on whether that plan has any annual deductible requirements. So, for example, if a patient is on Plan C, which means that they are receiving social assistance, the patient will actually pay 0 if they are receiving a medication that is fully covered. However, if that patient was on Plan I, which means that they're registered with Fair PharmaCare, that patient would pay full price for that medication until they reach their PharmaCare deductible. So if a patient is registered with Fair PharmaCare, the amount that the patient pays will depend on whether they're in zone X, Y, or Z. We'll now discuss PharmaCare's Lower Cost Alternative Program, or LCA program. As the name suggests, the focus of the LCA program is on the use of generic drugs. In the LCA program, if a generic drug is available, PharmaCare will only pay the cost of the cheaper generic rather than pay the cost of the brand name medication. So are generic and brand name drugs exactly the same? When patients ask this, we normally tell them that generic drugs follow the same manufacturing standards as brand name drugs. Generic drugs contain the same API, or active pharmaceutical ingredient, as the brand name. However, generic drugs may have different non-medicinal ingredients, size, shape, color, and markings. Generic drugs also meet Health Canada's standards for bioequivalence. If you'd like more information on generic versus brand name drugs, there's a link to an excellent article from the College of Pharmacy and Nutrition at the University of Saskatchewan. So how prevalent are generic drugs on the Canadian market? In 2020, generic drugs were dispensed to fill 73% of retail prescriptions in Canada. This is a growth of 2.2% compared to the previous year. The sales of generic pharmaceuticals accounted for 19.7% of the total cost of Canada's total annual prescription drug expenditures. Let's compare the costs of brand name drugs and their generic equivalents. The first example is atorvastatin 10 milligrams. Brand name Lipitor costs $2 per tablet. Generic atorvastatin costs about 19 cents per tablet. The next example is Ramipril 5 milligram. Brand name Altace costs $1 per capsule. Generic Ramipril costs about 9 cents per capsule. The last example is escitalopram 10 milligrams. Brand name Cipralex costs about $2.10 per tablet, and generic escitalopram costs about 33 cents per tablet. The bottom line is that generic drugs save government and third-party payers lots of money. We'll now discuss PharmaCare's RDP, or Reference Drug Program. In the RDP, PharmaCare is looking at different drugs within the same therapeutic class. There's 7 RDP therapeutic categories. There's angiotensin-converting enzyme inhibitors, we call these ACE inhibitors, dihydropyridine calcium channel blockers, histamine H2 receptor antagonists, non-steroidal anti-inflammatory drugs, we also call these NSAIDs, angiotensin receptor blockers, or ARBs, HMG-CoA reductase inhibitors, or statins, and finally proton pump inhibitors, also called PPIs. Within each of these RDP therapeutic categories, PharmaCare has designated a reference drug. The reference drug is usually the least expensive of the drugs within each therapeutic category, and they work just as well as the other drugs within the category. According to PharmaCare's Therapeutics Committee, these reference drugs should be considered as the first treatment of choice. This table lists the reference drugs for each RDP therapeutic category. For the ACE inhibitors, the reference drug is ramipril plus or minus hydrochlorothiazide. For the angiotensin receptor blockers, the reference drugs are either losartan plus or minus hydrochlorothiazide, candesartan plus or minus hydrochlorothiazide, telmisartan plus or minus hydrochlorothiazide or amlodipine, and valsartan plus or minus hydrochlorothiazide. For the calcium channel blockers, the reference drug is amlodipine. For the H2 receptor antagonists, the reference drug is ranitidine. For the NSAIDs, it's ibuprofen or naproxen. For the PPIs, it's pantoprazole magnesium or rabeprazole. And for the statins, it's atorvastatin or rosuvastatin. One thing to note is that for ARBs and the PPIs, in order for the medication to be covered for the patient, a special authority form needs to be submitted. We'll talk about a special authority on the next slide. Again, according to PharmaCare's Therapeutics Committee, these reference drugs should be considered the first treatment of choice. So for example, if you want to prescribe a statin for your patient, PharmaCare is suggesting that you prescribe atorvastatin or rosuvastatin. As I mentioned before, some medications need a PharmaCare special authority in order to be covered. A PharmaCare special authority grants full benefit status to a drug, medical supply, or medical device that otherwise would not be covered or would only be partially covered. In order to be eligible for special authority, the patient needs to meet specific criteria. One thing to note is that patients with a special authority may not get their medications for free. Even if a patient has a special authority in place, they may still have to pay depending on their PharmaCare plan and whether they've reached their PharmaCare deductible or maximum. This is PharmaCare's special authority webpage for healthcare professionals. As you can see, the table is organized alphabetically by generic name. In order to get more information about the special authority and the criteria, just click on the generic drug name. Let's take a closer look at the special authority page for candesartan, an angiotensin receptor blocker. At the top, we have the generic name, the various strengths, and a dosage form. In the middle, we have the special authority criteria. In order to be eligible for a special authority for candesartan, the patient has to be a person identified as experiencing an intractable cough or angioedema while taking an ACE inhibitor. To the right, we have the approval period. Note that the approval period in this case is indefinite, which means that once a special authority is approved, the patient has a special authority for the rest of their life. Other medications may be different, and the special authority may actually require renewal. Below that, we have the practitioner exemptions. If certain medications are prescribed by a specialist, say a rheumatologist or a respirologist, the specialist does not have to complete a special authority form in order to get that medication covered for their patients. The special authority will automatically be granted if the specialist prescribes that medication for their patients. Finally, at the bottom, we have a link to a specific special authority form to be completed and faxed to PharmaCare. In this case, there is a specific ARB request form, but for other medications, you may be directed to complete a general request form. If you have an urgent special authority request, you can call the Special Authority Physician's Line. The number is listed here. It's open Monday through Friday from 8 a.m. to 4 p.m. Urgent requests can be for either urgently needed medications or for urgent situations. Urgent medications include anticoagulants, oral antifungals, antibiotics, psychiatric medications, chemotherapy drugs, or drugs used for substance use disorder. Urgent situations include hospital discharge, palliative treatment, MAID requests, acute mental health, or life-threatening conditions. If you have a non-urgent special authority request, you can fax the completed form here. The estimated turnaround time is 1 business day for urgent requests and 10 business days for non-urgent requests. One exciting project is a Special Authority Transformation Project. So the BC Ministry of Health and the Provincial Health Services Authority, the PHSA, are streamlining the Special Authority request process. So you'll soon be able to submit Special Authority requests online through the PHSA eForms platform or even directly from your EMR. You'll receive notification and status updates so you can keep informed as to the progress of the special authority request. This transformation project promises a lighter workload, improved efficiency, and improved data collection. PharmNet is a very useful tool. It's a province-wide network that links all BC pharmacies to a central and secure database. Every single prescription that's dispensed in British Columbia is entered into PharmNet. It's used by community and hospital pharmacies, it's used by emergency departments, it's used by community health practices, and it's also used by the College of Pharmacists and the College of Physicians and Surgeons of British Columbia. You should be able to request access to PharmaNet through COMPAP. COMPAP is the Community Health Practice Access to PharmaNet, and it provides PharmaNet access to licensed physicians and nurse practitioners who are in good standing and who have a community practice site in British Columbia. Each practitioner must register for access, so if you go to the COMPAP website, you'll be able to download 2 forms that you need to complete. One thing to note is the College of Physicians and Surgeons of BC states that PharmNet review is mandatory in walk-in clinics and methadone clinics. There are many advantages to using PharmNet. PharmNet prevents accidental duplication of prescriptions and prevents prescription fraud. It identifies drug interactions and dosage errors. All healthcare professionals have access to medication information. It provides immediate adjudication of BC PharmaCare claims and promotes a cost-effective use of drugs. So what patient information can be found on PharmNet? You can find a patient's demographic information, their personal health number, their name, address, and date of birth. You'll also find their medication history. So below is a screenshot of a typical PharmNet medication entry. The information may be displayed differently depending on your vendor software. In this entry, you'll see the date the medication was filled, the prescriber, the quantity that was filled, the drug, the strength, the drug identification number, or the DIN, and the directions for use. The patient's medication history may include information about non-prescription medications. These may have been entered onto the patient's PharmNet profile either at the patient's request or at the pharmacist's discretion. Other information on PharmNet includes reported drug allergies and clinical conditions, drug interactions, and also claims information. As I mentioned earlier, PharmNet is a very useful tool. Feel free to call the pharmacy if you have a patient who's requesting a refill for a medication and they're unsure about the dose or even the drug that they're taking. The pharmacist can also check for reported drug allergies and even provide you information about whether a patient has received narcotics or controlled drugs recently. Thank you very much for watching. In the next video, we'll talk about prescribing best practices.